Okay. First of all, thank you very much for inviting me to this meeting. It's been wonderful to listen to even the couple of talks preceding. Unfortunately, I couldn't all of them. I attend all of them. And also, I was a bit apprehensive. I mean, I was not sure how I would really fit in, this fever being the focus of this. And, first of all, when Dr. Nagraj called me, I took a lot of time to dig out a case because he said, there has to be fever and there has to be a twist, with respect to the pathology. So I took a long time, to fish out this case. But anyway, it's been absolutely pleasurable and it's been a delight listening to Dr. Murli, the way he's analyzed each and every symptom, every laboratory investigation that's been provided to him, which is, I think, really nice. So now let's go on to see what happened to this patient. So as Sir has said, here we have a relatively healthy adult man, and I'm sorry for not providing the additional history. There was no significant family history. He was non-alcoholic, and the other tumor markers that you've asked us about, we haven't done it, so we don't know. So we have a man who's come with fever, abdominal pain, hepatomegaly, and what looks like multiple pyogenic liver abscesses on the imaging. And of course, let's also keep in mind that he seems to have a venous thrombosis. So this point kind of doesn't stick with the rest of it. But of course, the working diagnosis was that of pyogenic liver abscesses. So he was started on antibiotics right away. And it was found that there was no response in 72 hours. He seemed to worsen. And that was the reason there was a discussion between the surgeon and the interventional radiologist, who decided to go ahead and do an aspiration and send it for culture. So we were actually just called in when the IR was planning the aspiration. He said, why don't you all just do an FN2? Because this patient doesn't seem to be improving. So to our surprise, when the aspiration was done, there was no pus. In fact, it was repeated twice or thrice. We made 2 or 3 passes. There was absolutely no pus. And what we got instead was some serosanguinous material. We'd gone into the largest lesion in the left lobe, which was 6 centimeter plus. And of course, they were sent for all cultures, which turned out to be negative much later. Now, let me show you what the FN smears showed. Now, what you see is that there is a lot of necrosis. You don't see cells in the background. Now, if we were looking at a pyogenic liver abscess, the field should have been replete with inflammatory cells, particularly neutrophils. So we should have seen a lot of neutrophils, lymphocytes, which we did not see in this case. So, but there was this amorphous eosinophilic background, and there were some cellular clusters. So at this magnification, we cannot decipher what these cells are. So let's go and look at some more images. So some of these clusters were normal looking hepatocytes. So they had these bland looking nuclei and polygonal cytoplasm. And in some of them, there was bile, which was visible. So these were normal hepatocytes. So there was no nuclear atypia or no pleomorphism. So this made a diagnosis of hepatocellular carcinoma unlikely because we were seeing normal hepatocytes. But when we looked at other clusters, there were these large, irregular, very cohesive cells. And at this magnification, you can make out there is some nucleomegaly and hypochromatism. Again, there is more of these cells all over the field. And there is a lot of nuclear atypia. I'm not sure how many of you can appreciate it. You compare it with the hepatocyte, which was very bland, which had a normal nucleocytoplasmic ratio. Look at these cells. They have really bizarre, they have really large nuclei. There's no particular pattern of arrangement that you can make out. On the right side, you can see some of them have very prominent nucleoli, right? So these are clearly atypical cells. And at the same time, the presence of normal hepatocytes with this atypical cells, we were confused. So this was not in favor of a hepatocellular carcinoma. So we were not very sure what we were dealing with. And we didn't have enough material left over from the FNA to do ancillary testing. So we said, okay, this looks malignant. It's probably a carcinoma of the liver nodule. And we recommended that, give us some more material and better to go ahead with a core biopsy, considering the amount of necrosis that was there. So if we went in again for an aspirate, I was not sure whether we would get these cells or not. So there was a lot of discussion, debate between the IR and the surgeon, because considering his bleeding parameters were prolonged, doing the biopsy itself was a big risk. So, so it was corrected, the bleeding parameters were corrected, and then there was a true cut biopsy from the largest lesion that was undertaken. So these are images from the biopsy. You can see there are two cores, and the core on the right side is completely necrotic, right? There is no material there. So had we gone in again into an area, so we wouldn't have got anything. Luckily for us, the core on the left side shows the tumor. So this is clearly an infiltrating neoplasm. We don't see any normal liver tissue here. So what is the architecture? They are arranged in nests and cords, and considering that this is a malignant tumor of the liver, the first thing, of course, in our mind is it a MET? And if you consider metastasis, the most common metastases are adenocarcinomas. But we don't see any evidence of glandular differentiation, right? So we don't see glands. And if you want to think of squamous cell carcinoma, you don't see any evidence of squamous differentiation or keratin either. So whatever this is, this looks like it's poorly differentiated. But it has abundant cytoplasm. So you can see the amount of nuclear pleomorphism here. You can see the necrosis at the center. And you can also notice that there are a lot of mitotic figures. So again, even after doing the H&E sections, all we could say was that, okay, there is a poorly differentiated malignant neoplasm. The morphology is not in favor of a hepatocellular carcinoma. But remember, sometimes even poorly differentiated hepatocellular carcinomas can look like this. So we are not very sure. So then what do? We go to the next level. So what were the differentials we considered? Like Dr. Murli has already said, primary HCC versus METs. Now, this was a patient who didn't have any history of cirrhosis or hepatitis. And instead of solitary, these were multifocal lesions, although HCC also can rarely be multifocal. But we didn't have enough here to consider either of the diagnoses. So there was no cirrhosis, no cellular differentiation, and most importantly, there was no known primary. He didn't have any symptoms which could be referred to a pre-existing or a known primary, although we know that this lesion was chronic. So we went ahead with the panel of immunohistochemical markers. So the first thing, of course, on our mind was to exclude a hepatocellular carcinoma. So for this, we take the help of a marker called HepPAR1, which is a marker for hepatocellular differentiation. So this was negative, and this ruled out a diagnosis of hepatocellular carcinoma. So that leaves us with the diagnosis of metastasis. So most commonly, metastasis to the liver come from adenocarcinomas. And how do we approach these adenocarcinomas? So whenever we have a metastatic adenocarcinoma, either in the liver or the lymph node, wherever it is, when the primary is not known, we employ two markers known as cytokeratin 7 and 20, which is actually a cocktail of a low molecular weight and high molecular weight cytokeratin. So we look at the coordinate expressions of cytokeratin 7 and 20, which sort of tells you which direction you should be looking at. They are not absolutely specific, but they tell you where you should guide your imaging and tumor markers, right? So there's a whole list of tumors. I'm not going to go to the details. I'll just show you what we did. So when we did the cytokeratin 7 and 20, so cytokeratin 7 was strongly positive, whereas cytokeratin 20 was negative. Now, the cytokeratin 20 being negative is important for us because if you consider METs to the liver, one of the most common sites is the colorectal adenocarcinomas. Now here, cytokeratin 20 being negative excluded that possibility, right? So we were left with a long list of cytokeratin 7 positive, 20 negative tumors. As you can see, most of them are adenocarcinomas, but we should remember that sometimes there are some squamous cell carcinomas also which can express this marker. So with this, we went ahead and did some more markers. Now CDX2 and SATB2, despite the 20 being negative, we still did the colorectal markers. So these are more specific than cytokeratin 20, because if you look at the epidemiology, colorectal carcinomas are more commonly in metastasizing to liver. Of course, we did a chromogranin to exclude neuroendocrine tumors, chromogranin synaptophysin, which were negative. And later on, we came back and even did a TTF1, which was negative. Now, the other set of markers, remember I told you that cytokeratin 7 can also be expressed in squamous cell carcinomas. So which is the reason we went ahead and did a P40 and a P63. So you see this diffuse nuclear staining of P40 and P63, which is very specific for squamous cell carcinoma. So what we were looking at here is a squamous cell carcinoma. Now the question is, are we looking at a primary squamous cell carcinoma or are we looking at a MET? Because we don't seem to have an evidence of a primary anywhere else, right? So our work, but considering the clinical situation, the presence of multiple lesions, and the primary squamous cell carcinomas of the liver are extremely rare, right? So they usually occur in the setting of either some kind of a biliary cyst or a long-standing cholangitis or calculi, which is, I mean, you know, there literally, I think, not even like 25 cases of SCC of the liver which are reported. So considering the rarity of the lesions, we tilted more towards a diagnosis of metastatic squamous cell carcinoma. So we conveyed this diagnosis to the physician, to the surgeon, and then they were debating what to do further. So they were planning for further imaging. So before I tell you what happened to the patient, a small discussion about liver mets. So liver accounts for about 25% of all metastases from all cancers, and majority of them are adenocarcinomas. And the common primary sites are colon, pancreas, and stomach. Neuroendocrine carcinomas and squamous cell carcinomas are less common. And one point to note is that neuroendocrine tumors and lung carcinomas, even though they may be very small in size, they can give rise to liver metastasis. So we can never exclude it. And the thing with squamous cell carcinomas is that there is no site-specific marker. So there's nothing which tells you where the squamous cell carcinoma came from, except for P16 expression in head and neck squamous cell, some of the head and neck squamous cell carcinomas, where it is used as a prognostic marker. We don't have a site-specific marker, unlike we have for adenocarcinomas. And SCC is a very uncommon tumor which metastasizes to the liver and commonly comes from esophagus, anorectal, or the head and neck regions. So the next is fever and cancer. So now this patient presented with fever. So all the features were pointing to an inflammatory or an infectious cause. So when we dug up literature, we found that fever is not so uncommon in patients with malignancies, but most of them are cases of lymphomas and leukemias rather than solid organ malignancies who present with fever. But nevertheless, malignancy is an uncommon but important cause of PUO. So it's way down the list, but still you have to keep it in mind. And there are different mechanisms for production of fever in patients with cancer, which I think the audience knows much better than I do. So I'm not going to go into that. Now, coming to the imaging. Now here we had multiple liver lesions that were mimicking liver abscesses. Now, both the converse is also known. You can have infections in the liver that mimic malignancy and vice versa. So which are the tumors which mimic liver abscesses? So most famously, they are intrahepatic cholangiocarcinomas, hepatocellular carcinomas, and any tumors which have a lot of cystic lesions. So on a plain MRI alone, it may be difficult to differentiate a liver abscess from a metastasis. So it is suggested that you do a diffusion weighted MRI, which would help to differentiate a metastasis versus a liver abscess, of course, which was not done in this patient. And to tell you about the clinical course, what happened to this patient. So right after we conveyed the biopsy report, so the patient developed sudden onset of breathlessness. And he had a contrast enhancing CTPA done. And you can see that there are bilateral pulmonary thromboembolisms. In addition, there is a solitary nodule in the right middle lobe of the liver. Okay, so they were contemplating, considering his situation was worsening, so they were contemplating whether to do a biopsy of this, whether it would be feasible or not. And he was on adequate anticoagulation. Despite that, he did not survive and he succumbed to the, it's very unfortunate that he succumbed to the thromboembolism. So finally, we decided that this was most likely a metastatic squamous cell carcinoma of the liver, with the radiology favoring a lung primary, although we could not get a histopathologic confirmation of the same, considering the stormy course the patient experienced. So there were a lot of lessons that we learned from this case. The first of all being that Hepatic mets, although common, they can have very unusual presentations like pyogenic liver abscesses. So the good thing here was that there was a constant discussion. There was a multidisciplinary discussion which was going on between the surgeon, the radiologist, the pathologist. So as early as 72 hours after starting antibiotic, they took him up for a biopsy. So they felt there is something unusual about this case which needs a biopsy rather than waiting for long. So there was an early FNA biopsy done, which facilitated the diagnosis in this patient. But nevertheless, it is unfortunate. Despite doing all this, using immunohistochemistry, the young patient could not be saved, which is unfortunate. So this case goes to show that, you have horses and you have zebras, and you might have just that one zebra, which is among horses, which you might miss if you don't do timely reviews and multidisciplinary consultations. So cliched as it may sound, it is always teamwork that prevails. So thank you very much for inviting me to this meeting. And I'd like to thank Dr. Sridhar, whose case this was, for kindly sharing all the clinical details with me and enabling me to present this here. Thank you very much.